Chinmay Marathe. Karen, my voice is okay? Because,
yes, it's fine. We can hear you.
Yep. All right. Thank you. So I am an endocrinologist based at the Royal Adelaide Hospital, and I work, I spend about 30 days a year on average at 2 remote Aboriginal healthcare centers in South Australia. So, and I've been doing that for the past 4 years or so. So by no means an expert on the cultural aspects of managing the disease, but what I thought I could provide you with is an update about diabetes with a focus on how it affects and disproportionately affects the Indigenous community. Okay, next slide. So essentially, we'll have the following topics for discussion. This would be an overview of diabetes, and we'll talk about the micro and macrovascular complications. Next slide. With some focus on diabetes in Indigenous Australians. And I thought I'd also include some on diabetic foot disease. So at the outset, I was going to apologize that there may not be a lot of things applicable to nuclear medicine, but it'll be a long list of apologies given that it's been late by almost 25 minutes. So I'll try and a few applications, as you very well know, with management of diabetic gastroparesis, where scintigraphy is a gold standard technique, and also the use of PET scans for other, particularly in diabetic foot disease, for infections. So you will deal with people with diabetes on a regular basis, and I will touch on those as we go along. Next slide, please. So this is the sort of general slide. You start with the projection for the future. So what you can see on the slide is the prevalence of diabetes on a worldwide scale in 2013 and the projected rise in 2035. And as you can see, in most parts of the world, including Australia, the prediction is that diabetes is on the rise. But as all predictions go, this assumes a few things, including that will keep going at the current rate, and we may not have treatment therapies to stop it. So at the moment, you do not have cure for diabetes, we have only management. And if that continues to be the case, then we are looking at the rise in diabetes across the world, including Australia. Next slide, please. Just a brief overview. There are a few types of diabetes, but the two common types, as you will know, are type 1 and type 2 diabetes. Type 1 affects about 10% of all people with diabetes. So type 2 is the more common one. And here's a slide from the US. So in terms of Australia, we think about 5% of Australians have diabetes. 90% of those, of the 5%, will have type 2 diabetes, that is the common type of diabetes. About 10% of the 5% will be type 1. Okay, so 5% of Australians have diabetes, and also there'll be a number of people who are not aware that they have diabetes. So this is a conservative estimate, and most of that 5% will be type 2 diabetes. Next slide. And the classic way to diagnose diabetes in the past, if you look at this table, was the row at the bottom, which was the 2-hour glucose tolerance test. Usually a glucose drink containing 75 grams of glucose is given to an individual. You take blood tests before they take the drink, and then it's regular intervals after. If the 2-hour glucose reading is high, then it's referred to as somebody having diabetes or having pre-diabetes, or what is known as normal or normal glucose tolerance, somebody without diabetes. So that used to be the common way of testing diabetes or diagnosing diabetes. It still is common around different parts of the world. However, in Australia now, it has been superseded by what is known as the hemoglobin A1C, or glycated hemoglobin, which is a single point blood test, which tells you an average over 3 months. And this comes as percentage. Generally, people under 5.7%, or some say about 6%, would be referred to as not having diabetes. This is a single point test, doesn't need to be, people don't need to be fasted. Somebody with a level above or equal to 6.5% would be said to have diabetes. And if you fall in the in the middle, so somewhere between 5.7 or even 6 to 6.4%, then that would be referred to as pre-diabetes. But that the change has been that we have moved from largely from a 2-hour glucose drink test to now a single point blood test. Next slide, please. And diabetes is a old ailment. The earliest one are from the Egyptian papyrus about 1550 before Christ. There's also some records in 5th or 6th century from India, where they coined the phrase honeyed urine for diabetes. And that's, so it's been known for a while, but treatment for diabetes, the modern treatment is fairly new. Next slide, please. And the real story starts in 1920s. And this is a famous photograph from one of the terraces at the University of Toronto. You have here on your right, you have Banting, his medical student Charles Best. They both won, along with a couple of other people, the Nobel Prize for discovery of insulin. And at the most important in the photograph is the dog Marjorie, who was the one on whom they performed the experiments and removed the pancreas to render her diabetic. Marjorie unfortunately died a few months after, but she played an important role in discovery of insulin. And this year is the centenary year of discovery of insulin. So 100 years since that. Next slide, please. And this really revolutionized treatment, at least for the people with type 1 diabetes, who are essentially reliant on insulin to survive. And the first patient who got this insulin was Leonard Thompson, who received this on 11 January 1922. And that was literally a lifesaver for him. And he lived for another 19 years, I understand. He succumbed to pneumonia, but then that was, he had good quality of life since the discovery of insulin. Next slide. So that's Leonard, a couple of his photos before 1922. On the left is where before the availability of insulin. So insulin is an anabolic hormone. It makes your body, you build muscle and fat. So as you can see here, is extremely wasted, unwell baby, and then following insulin being available, you can see that he has become a lot more chubbier. For some reason, he doesn't appear happy. He still is glum, but I think you would say that he appears to be slightly healthier than the photograph on the left. So this was a big change. The availability of insulin did change a lot of things for people with diabetes. Next photograph. Next slide, sorry. Yeah. And so now diabetes is a problem which is a multi-vessel, multi-system chronic disorder. And generally, the complications of diabetes are classified according to the organs or the blood vessels which supply these important organs. So you will see that a lot of people will divide these complications as being microvascular, which means that is involving the blood vessels to the eyes, kidneys, and the nerves of the hands and feet, and the macrovascular, which is the big blood vessels supplying the brain, the heart, and the foot. So if you have microvascular damage to the eyes, it can lead to blindness. To the kidney, can cause kidney damage, ultimately resulting in dialysis. And if it affects the nerves, then you have numbness and other problems with the feet. If it affects the big blood vessels of the brain, that can lead to strokes. If it affects that of the heart, can lead to heart attacks. And also the foot is a special case because it involves a small vessel, the large vessels to the foot, so can affect your circulation, but also affects the nerves, and they do damage, so it can cause numbness. And we'll discuss about the foot towards the end of the presentation. Next slide. So I thought with each of these complications, I'll just give you an overview of what we tend to look at. So people with diabetes, particularly type 2, about 4 or 5 years after diagnosis, they are asked to have a eye check every year. Um, 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 and they would have a photograph would be taken of the back of the eye. And if there are some spots of bleeding or there are presence of new blood vessel, that's an indication that there has been damage to the eyes, and that requires prompt assessment. So this goes a long way in preventing blindness. So that's one of the things that is checked in people with diabetes every year. Next slide. The others are kidney. Next slide. And again, it's with the kidneys again, you start having early damage because of diabetes. And what tends to happen is that there is increasing leakage of protein, particularly albumin, from the kidneys. This results in a lot of albumin in the urine, known as albuminuria. And this again is an early marker of kidney damage because of diabetes. It doesn't indicate that the kidneys have failed, but this is an early marker. This is the time to act and potentially reverse the condition. So for the eyes, we do annual eye checks. For the kidneys, there's a simple urine test which looks for the presence of albumin. There's a certain cutoff, and it's above that, then you need to aggressively target the diabetes, blood pressure, and that to try and retard the progression and ideally reverse the process of kidney damage. Next slide. And you can see here that the normal on the chart at the top, and you will see that the normal kidney albumin levels would be in the range of in the units are the ones we use in Australia to the right, so milligrams per millimoles. If it's less than 3, that's normal. If it's between 3 and 30, it is the microalbumin, a little small leakage. This is where a diabetes specialist gets interested. And then when you start having lots and lots of albumin leakage, here's where a kidney specialist needs to be involved. So, but the idea is that we don't wait for the kidneys to be damaged. You try and do these checks early on, annually. A lot of people get this every 6 months to make sure that there's not excessive leakage of albumin in the urine. Next slide. And then we have neuropathy. Next slide. So these are some of the patterns, the classic patterns of nerve injury in people with neuropathy. And what you have, the one in the figure A, that is the classic pattern of nerve damage, which means that's called glove and stocking, which means that the nerves, the more peripheral nerves, tend to get affected first. So you get numbness, tingling, burning sensation, electric shocks, all start in the toes and the fingertips, and then they progress towards the center of the body. That is the classic pattern, but you can also get patchy involved, as you can see in figures B and C. And in D is where, which indicates there could be, apart from the peripheral nerves, it can also affect what are the autonomic nerves. These are involuntary nerves. They're not under your voluntary control, and they control important functions in the body, such as the heartbeats, because of involuntary autonomic nerves. The stomach motility, digestion, all happens because of that. And all of these could also be affected. So you get nerve damage, not just to the feet, but also involuntary nerves affecting the heart and the gut, and that could also be quite damaging. Next slide. Amongst these autonomic or involuntary nerves, the most lethal is the one which affects the heart. And more as we're getting aware of this. Historically, this has been neglected. There are always case reports of people with diabetes who die suddenly without any explanation, often in the middle of the night. And one explanation could be that they have too much of insulin overdose, but also another explanation could be is that they have silent heart attacks, which can happen because of nerve damage to the heart. So it's something that is increasingly being aware of, but the one we worry about most is the heart. However, these involuntary nerves, as you can see in this figure, not just innervate the heart, but a whole range of organisms, starting from the eyes and to your lungs, your kidneys, or also importantly, if you look on the around sort of 9 or 10 o'clock above the liver, also affects the stomach. Next slide, please. And so most of you would be aware of or would have been involved in measuring gastric emptying. Often we have to refer people with diabetes to have their gastric emptying formally quantified, because one of the problems, because of the autonomic nerves damaging, the one supplying the stomach and the intestine can get damaged and can result in delayed emptying. Abnormally delayed emptying is known as gastroparesis, and the gold standard technique is the nuclear medicine technique of scintigraphy. There are other techniques such as breath tests, which can be an alternative to it. There can be ultrasound, but with everything with ultrasound is observer dependent. However, the gold standard technique is scintigraphy. So it's quite possible that you would be involved in this. So that's a little angle I can bring to of relevance to you. Next slide. And then we move on to the other macrovascular, which are the ones which affect the brain, heart, and the feet. Remember, the ones on the left, the eyes, kidney, and nerves, they are the major cause of disability, but the ones major cause of death would be the strokes and heart attacks. So the macrovascular kills, microvascular maims. Either way, it's not a good thing. So diabetes control is essential. Next slide. And so here's a little blurb on the macrovascular complications. The term is atherosclerotic cardiovascular disease. It means that there are blockages in the big blood vessels in the body, which supply the heart, the brain, and the big blood vessels to the limbs. And it's the leading cause of morbidity and mortality in diabetes. And diabetes is an additional risk factor for this. The issue with glucose control has been that while the link between good glucose or sugar control and the microvascular complications, which is eyes, kidneys, and the nerves, is very well established, the link between glucose control and the macrovascular, the one supplying the brain and the heart, is not as clear. So what is important here is depends on something called a metabolic memory. For example, somebody with diabetes, if they've had 10 years of very poor control, haven't looked after themselves, and then you go in and control the sugars, you might be able to reverse some of the nerve damage, you might be able to slow down the kidney and the eye damage, but you may not be able to get major wins with the risk of having a heart attack. So in the short run, if, however, they continue for a few years with good control, then only you see benefits. So it's so with these big blood vessels, or it's not only sugar control is important, but other things such as maintaining their blood pressure, the cholesterol, stopping smoking. These things are equally important in the short run as lowering glucose. Next slide, please. So, but overall, for the microvascular, the vessels, it is very clear that if you have better sugar or glucose lowering, you will prevent the microvascular complications. And the landmark trial is the DCCT. Next slide. And for type 2, this was the UKPDS, both the DCCT, which was done in the US, and the UKPDS, of course, in the UK. They were published in the 80s to early 90s, and that is when you had it was established that at least for the microvascular complications, glucose lowering was essential. One other major problem with glucose lowering beyond a point is that if you are very aggressive with glucose lowering, there is the risk of hypoglycemia, which is abnormally low blood sugar, and this is and the risks of those have become clear in the last decade from the results of at least these two prospective trials, the ACCORD trial and the ADVANCE trial. Australia was involved, I think, in the ADVANCE trial, and where you had two arms. People with diabetes, type 2 diabetes. One arm was so-called conventional control, where you had glucose lowering less than 7% of HbA1c, which is the traditional target, and another was the intensive control, even lower at less than 6 to 6.5%. The hypothesis was that if you lower glucose even more than the conventional target, your outcomes would be better. What happened was the opposite, that there were more deaths in the intensive control arm, and they had to prematurely stop the trials. And the reason for that was that in the arms where you had very low glucose lowering, you increase the risk of hypoglycemia, and hypoglycemia was a stress on the heart and also triggered a whole set of autonomic stress factors, and that was probably the reason for increased mortality. So now the targets, you no longer stick to one target. You try and aim for less than 7%, but it all depends on individual circumstances. Moreover, if you have, as I said, there's a concept of metabolic memory. So if people have poor control for years on end, then just jumping in with good glucose control may not give you the best outcomes in the short run. Next slide. And so rather than a simplistic less than 7% or 6.5% target, the approach has become slightly more, it's more personalized, it's more individualized now. And you look at the number of factors for your patient, and depending on that, you decide what a target would be. For example, somebody who's 40 years old, otherwise, no other risk factors, expected to have a normal life expectancy, whatever, in the mid 80s for Australia, then you would try and get them under 7% as much as possible without increasing the risk of hypoglycemia. On the other hand, you have somebody who's, say, aged 88 years, lives alone, is possibly going blind, has only one leg, or is a risk of falls, then you might be happy just accepting something under 8%. So the thing is that you're not as stringent with your control if somebody has a number of comorbidities, or the expected life expectancy is not very is short. So these are a number of factors that you consider before deciding what would be a target for your patient. Next slide. And this is just an overview of saying what we have got now in terms of treating for diabetes. So I told you earlier that before 1920s, there were not really good treatments for diabetes. And 1921 was when insulin became available. And then in the last few decades, been a plethora of treatments available. Some have been even withdrawn from the market. But at the moment in Australia, for a person with type 2 diabetes, there are at least 6 types of different oral medications and 2 types of injectable medications. One of them is insulin and another is a non-insulin injectable option. Next slide. And what you can see here is that there are a number of, as I mentioned, diabetes has a number of, it's a multi-system problem, and therefore all these different medications target different aspects of diabetes. And what you can see here is some of them cause weight gain, some cause weight loss, and some are weight neutral. So the reason for this is that we have lots of choices, and we can now tailor the combination of treatments depending on an individual's requirement. Next slide. And so what has happened is that with the advent of this medication as well as insulin, the people with diabetes are living longer. And that means that it's coming at the cost that if you can manage the problem, they're not dying early, but they're now living longer, but they're having more duration when they're having chronic complication and they have increased morbidity. It's come at a cost. It's still better than not having treatment options, but this means that people are living longer, and therefore we're seeing more and more complications. Next slide. Another thing I want to just introduce is the fact that we are currently living in an era of a number of cardiovascular outcome trials for medications with diabetes. So what happened in the early 2000s was there was a class of diabetes medication called TZD, or thiazolidinediones. And they came with a lot of fanfare, as had been the previous class of diabetes medication, and they were meant to improve insulin sensitivity and a whole sort of other things. Unfortunately, this class of drug it had deleterious effects on the heart, particularly heart failure, and they had to be withdrawn. At least one of the drugs had to be withdrawn from the market. And after that, what happened was the US FDA mandated that every drug for diabetes, before it gave approval, had to do a large-scale cardiovascular outcome trial. So the drug companies were forced to spend millions of dollars to have adequately powered trials to first show that the diabetic medication did not harm the heart or the kidneys. So the companies did not want to do it, they were forced to do it. And therefore, what you see in the last 10 years or so, a plethora of cardiovascular outcome trials that that have been published, and there are still some on the way. Every year there are a few being published. And next slide. And there is some sort of silver lining to it. And what has emerged is, one is, reassuringly, the other classes of most of the diabetes drugs available do not harm the heart, but a couple of them, the SGLT2 inhibitors, which work through the kidneys, another one called the GLP-1 receptor, actually not only not harm the heart, but are actually beneficial to the heart and kidneys. And it's probably something that the cardiologist or the nephrologist, the kidney specialist, have not had before. So clearly a result of being forced to do these trials, the two classes of diabetes lowering drugs have been found to have very beneficial effects, possibly beyond whatever is available to the cardiologist or the nephrologist. And this is purely accidental because they were forced to do it. So one class of them is the SGLT2 inhibitors. In Australia, the something called Jardiance and Forxiga are available. I'm just letting you know because when you have procedures, particularly longer procedures, you will find that these drugs, the patients are asked to withhold these drugs for a while. So you might just see this, that people, if they're on the drug and if they have a particularly long fasting period, you might have to readjust when they have the test done. Next slide, please. And these are some summary of the cardiovascular outcome trials where you see that they have beneficial effects. So something called as 3-point MACE, which is major adverse cardiovascular events, which means a non-fatal heart attack, non-fatal stroke, and cardiovascular death. And these drugs, this class of drug, particularly the one, the empagliflozin, the canagliflozin, and the dapagliflozin, have beneficial effects on the heart and also the kidneys. And you will see that these drugs are going to be used more and more. And there's also a role for these drugs, even people without diabetes who have established heart disease. And that's all new evidence that's coming through. Next slide. The other class of drug which has been fortuitously seen to have beneficial effects for the heart and possibly the kidneys is a GLP-1 receptor agonist, which have to be injectable for the large part because your oral tract would destroy the peptides. And these again work on the stomach primarily, but also on the brain. And these have they slow the stomach emptying, but also lower the blood glucose by also probably targeting the fasting glucose levels. I've just tried to show you what is available in the market around the world. Thankfully, in Australia, we have only we pretty much have three injections available. These agents also cause a lot of weight loss. So one of them has been indicated in Australia at a higher dose for people without diabetes, just for weight loss. So we have out of these only three for diabetes and one for weight loss. So, but globally, as you can see, there's a whole expansion in these two classes of drugs, the SGLT2 inhibitors, which are oral tablets, and these GLP-1 receptor agonists, which are injections. So that those have been positive effects of the forced multi-million-dollar cardiovascular outcome trials that was mandated by the US FDA. Next slide, please. And this again gives you a summary of the beneficial ones, which have been beneficial. The first, sorry, if you can go back. Yep. So just gives you a summary. If somebody's interested, I can go through that. But generally, some of these agents, particularly the first one, the liraglutide in the LEADER trial, the semaglutide, but in the SUSTAIN 6, and applicable to us is the REVINE trial, dulaglutide. All of these drugs, they have positive effects on the heart, possibly the kidneys, besides being excellent for weight loss and also for glucose lowering. So that is the new sort of what's new in diabetes, is that you have a couple of classes of diabetic medications which not only effectively lower sugar, but can cause weight loss and are beneficial for the heart. So, and as I mentioned earlier, it is the cardiac effects, the effects on the brain, that is what people die of in diabetes. So that this has been a very welcome addition in trying to prevent mortality in diabetes. And this, of course, has implications of people with in the indigenous communities. Next slide. So with that background, I will give you an overview of the diabetes in the indigenous Australians. As you can imagine, people in the indigenous community are disproportionately affected. So next slide, please. So this is the South Australian data, but also you will find that similar data would be seen in other parts of the country, where you see the prevalence of type 2 diabetes. And you can see that overall, the prevalence is quite high. The studies, as I will show in the next slide, that there's a wide variability in the studies, but it is at least 3 to 4-fold higher. So you'll see both genders, it is higher than the non-Indigenous population. Next slide. Also, if you see with, as I said, the studies are the best that could be done. So diabetes was where we could do, you got HbA1c, but in others it was just seen as, self-reporting patch of diabetes. Again, you will see that the prevalence in the community is much higher than the so-called 5% that we have for the rest of the country. I've seen figures as high as 30% in some Aboriginal communities. What is also, as you can see on the graph on the right, is that the characteristic of this problem is that it affects people in the indigenous communities at a very young age. So you do see a high proportion of people 45 plus, and you can see the percentage above 50%. But sadly, it's also very high in the young, over in the above 25. There's still sort of 12% or so that starts creeping up. And of course, there's a lot of variability, but unfortunately, that is one of the characteristics, that it's the course of diabetes is aggressive in this community, but also the younger age at onset. Next slide. And so if you look at the sort of the prevalence, I've said that, it's anywhere from, say, 14, but it can be as high as 33%. Compared with 5% rest of the community. So clearly disproportionately affected. And after age adjustment, Aboriginal and Torres Strait Islander people are at least 3 to 4 times more likely to have diabetes. Next slide. And as I mentioned, sadly, the incidence is the sort of the contrast becomes quite stark at young age. It's not clear what proportion of people have type 1 diabetes, the less common. You would assume majority would still have type 2 diabetes, but really in the 10 to 14-year-olds, it's 8 times more common in the community compared to the rest of the country. And at least in the 15 to 20 or thereabouts, it's 4 times more common. So very aggressive disease, generally more common, but tends to affect young Indigenous Australians much more so than the non-Indigenous communities. Next slide. And again, this again should not be surprising to you, is that compared to sort of rest of the country, in the Indigenous adults, the proportion of people with diabetes, it really is partly related to your place of residence. And so generally, not surprisingly, but people who live nearer to the major metropolitan centers, they would be the proportion of people with diabetes will be lower. And as you get onto the remote and very remote areas, that tends to go up. Next slide. And also this has an impact on hospitalizations. So you can see that, again, South Australian data, but this is representative, I think, of the rest of the country, is that much higher hospitalization for Indigenous Australians if you adjust for age. And this all goes back, the last data we have is sort of 10 years old, but we haven't got the latest data collected. So we don't know whether things have improved, but certainly, as you can see, that there is quite a gap between the two bars. Next slide, please. And also, again, at each age, there seems to be more. And as you can see, sadly, it's the hospitalization is also on the higher side at younger ages. Next slide. So just a bit of a snapshot of what we discussed with hospitalization. The data we have, again, as I said, it's patchy data. So what I could find was the 2012-13 data. At that time, after age adjustment, you were about 3-4 times more likely to be hospitalized. People ATSI stands for Aboriginal Torres Strait Islanders. A proportion of women will during pregnancy will have gestational diabetes, and for that they're at least 2 times more likely. This is important because that gestational diabetes predicts if you have diabetes in the future, and therefore again that is more likely in the community, and in general 4 times more likely for type 2 diabetes. Next slide. So as a response to this, there was a sort of a consensus statement which came, I think, in 2020. Largely, as you can see, what we should do with Aboriginal and Torres Strait Islander adults under the age of 35, because diabetes is a major risk factor for heart disease. Heart disease is what accounts for this large gap. You might have heard about the life expectancy gap between Aboriginal and non-Aboriginal communities in the country, and it's anywhere from 10 to 15-year life gap. A large part of that is because the disproportionate cardiovascular death, in turn because of diabetes and kidney disease. So in response to all this statistic, a consensus statement was published in 2020. Next slide. Which relied on this national heart risk algorithm, which takes into consideration presence of diabetes, your age, whether you have the early kidney markers of kidney damage, whether you have absolute kidney damage, your blood pressure, and cholesterol. But next slide. And a shift was made from previous The major shift that's been made in this area is that you would start, instead of the age of 35, you would now, if there's an Aboriginal person, you would do a proper full assessment at age of 30. And even above the age of 18, you would still try and screen for these risk factors. So while you would not do a formal assessment under the age of 30, you would still be actively looking out, because as I showed, there's still some prevalence of diabetes, and it tends to occur early, and it tends to be aggressive. Now, the national calculators, the lowest age is 35. So the recommendation hasn't really been reflected in the calculator. If you were to do it, you would just, if there's an Aboriginal person who's 31 years old, you would put their age as 35 in the calculator, because that doesn't take into consideration at the moment these recommendations. But I'm sure that in a few months or couple of years, you'll find that there'll be a separate age risk calculator for the Indigenous community. Next slide. That's been the major change, that at least from 18 years, it would be actively doing cardiovascular risk factor screening, and from the age of 30, you undergo absolute risk factor according to the National heart risk algorithm. Next slide. Okay, so with that, how am I doing for time, Karen?
Oh, I think that you're okay, Chime. We are over, but
Yeah.
you know, we are going to record the presentation. So if
Sure.
some of the technologists need to leave for other commitments, they will be able to log on at another time to
Okay.
watch the rest of your presentation.
All right. So I'll probably go briefly through the last section, which is the foot in diabetes, the foot disease, because again, it's a unique problem which affects both the microvascular and the macrovascular aspects of complications of diabetes. And again, it's a serious problem in indigenous communities. Next slide. So again, the statistics generally, they're quite shocking with foot disease in Australia. So you have about, if you say you had about anywhere 5% or 1.2 million or different, you get statistics, about 4,500 total amputations performed per year on the, these are lower limb amputations, both what is regarded as minor amputation, which means, it's only a toes to midfoot, or major amputations beyond that. Large number of admissions in the country, at least 10,000 per year for diabetes foot. This thing again costs a lot of money, and also there are a whole host of hidden costs. And also with good care, the cost, a lot of this could be saved. Next slide. And just what is the risk of developing a foot ulcer? People don't realize that a person with diabetes, the lifetime risk can be as high as 34%. Generally, the average of studies seems to be 25%, but it can be quite high. What is the annual incidence of ulcers and diabetes? Well, it depends on the population. So 2% is the general community. If you did in this 6% was the figure in the US war veterans. So it depends on maybe dependent to a particular group. That is very high. We do not know what it is in Aboriginal Australians, but we would think it's greater than 2%. Why do we worry about a foot ulcer? Because most of lower limb amputations are preceded by an ulcer, 85% or so. However, at least in the developed countries, in people seeking contemporary healthcare, there is some suggestion that there may be a decline in diabetic foot ulcer incidence. And this is data from the US. And again, it's quite broad, where it says any lower limb ulcer or inflammation or infection. And what you can see with the worms, at least they're not going up. So it's either stable or going down. And so we have to live with how the data is collected, but it's not on the up. So possibly in the last decade, with some with more awareness in the general community, we would think that there is either stagnation or even slight reduction in the ulcer incidence as determined by hospital admissions. Next slide. And so this is a local Australian paper, and I thought I'd include it here, is every year the World Health Organization comes up with these top 10 causes for global disability. And the number one cause is low back and neck pain. And diabetes comes as number 6. And so with this group based in Queensland and partly in Adelaide, they extrapolated that if you account for, disability because of foot disease were a category, which the WHO does not recognize, but if it were a category by itself, it would be in the top 10 causes of global disability. Okay, so it's a serious problem, and it does, cost not just the person, but also the healthcare system. Next slide. The quality of life is pretty poor. Again, this is pooled data. This is UK-based data on something known as EQ5D scores. These are quality of life scores. If your score is less than 1, as it is, you have very poor quality of life. And if you look at this sort of pooled data, they were not done altogether, just pooled with other data. If you look at major amputation of foot ulcer, you will see that the numbers are less than 1, less than 0.5. And if you look at what it compares with, it's a grim picture, where these are people with dialysis, these are people with breast or prostate cancer, those with chronic lung disease, chronic kidney disease, those with strokes or heart attacks. So foot disease, quality of life is bad, and again, it's one of the major causes of of global disability. Next slide. And so this is sort of the rates of diabetes related lower limb amputation. How has Australia fared? In its own backyard, not too poorly, and that's not surprising given the competition. But and also the fact that what we have in Australia's backyard is our communities which have a higher predisposition, like the Aboriginal communities, for diabetes, and therefore you see that generally healthcare, access to healthcare, availability of surgical expertise might be variable, and therefore Australia doesn't do that poorly in its own backyard. Next slide. A better sort of comparison would be how it fares in the so-called OECD group of countries, which is a group of so-called developed countries. And in 2010, Australia wasn't doing very well. So it was the second worst in the OECD countries, and it has fared better, it's made progress. It's now the 10th best in 2020. And while clearly in the last 10 years, there's more awareness and more resources being put towards this, if you look at the composition of the OECD countries has also changed. More and more countries have been brought into the OECD group, and which has expanded in the last 10 years. And now you have some Eastern European countries. You have, I think, Turkey, which is part of it. And down the track, I think China and India have also been invited down the track. So if you look at the competition, Australia might keep doing better, but part of it might be because of its own efforts, but other part might just be that the competition, the other competitors in the OECD group of countries. New Zealand, on the other hand, have consistently been better than Australia, either in 2010 or 2020. You can appreciate, though, that the geography of Australia, there's a considerable disparity based on geographical location, socioeconomic strata, and also ethnicity. Next slide, please. And so this is a snapshot of the amputation rates in Australia, where you can see that the higher the rates, amputation rate per 100,000, the darker the shade of blue. And so you see, not surprisingly, that in the metropolitan major city centers, you will see that the better access to healthcare and the amputation rates tend to be lower. And as you go towards to the country or more remote areas, it tends to get higher. Next slide. And the pattern is seen locally in South Australia as well, where the better rates or lower rates of amputation are closer to Adelaide. And as you move further from Adelaide, the amputation rates seem to go up. Next slide. So Indigenous Australian, and these are still the data that we can get. At least, as I said, 3 to 4 times more likely to have diabetes, but they're at least 10 times more likely to be admitted with diabetes-related complications. And according to one study, and there have not been too many studies, this study concluded with 30 times more likely to undergo diabetes-related amputation. And if this were true, we know it's higher, but it's a bit surprising. It's 30 times more. If this were true, then a large part of that would be access to care, and whether the concern is people with foot disease, are they presenting much later than we'd like them to. Next slide. Next slide. This is the pathogenesis of foot ulcer. Very quickly, it's multifactorial. How do people with diabetes develop ulcers? The reason we talk about ulcers is because 85% of ulcers precede amputation. And so it's a combination of factors. Usually one thing cannot cause it. So because of diabetes, high sugars, you have both muscle wasting and damage, you have nerve damage. All of that changes the architecture of the foot, increased foot pressures, foot deformities. Then you can have autonomic neuropathy, which supplies this, sweat glands in the foot. So if you have damage to that, there's dry skin, which forms callus. It can also affect the blood flow. All of that, you have those things going on in a person with diabetes, and then you have some trivial insult or injury, whether there's a small pebble that gets stuck in the shoes, or you're walking barefoot. There are, when I go in the country, there are lots of Aboriginal people who do not wear adequate footwear, or have been walking, particularly in summer, barefoot on hot soil. and then because they have neuropathy, they do not. So what is we refer to the gift of pain, which means that if you do not have neuropathy, you don't have diabetes, if you step on a hot say metal or soil or fire, you would feel the pain and you would step away from it. But with people with diabetes, because they have nerve damage, they do not perceive this pain. Because it's not perceived as being something risk, they tend to disregard that injury and then only present much later with foot ulcers. So this is one of the common patterns that we tend to see. Next slide. And so what are the types of foot ulcers? Very quickly, on the left is purely because of nerve damage. On the right is purely due to lack of blood supply to the foot. And in the middle is a combination of both. And this now, previously, the one on the left, the neuropathic, used to be the most common type of foot ulcer cause, and now it's becoming neuroischemic. So you have component of both blood flow damage as well as nerve damage. Next slide. The reason that's important is because you have the ones with blood flow involvement, whether it's ischemic or neuroischemic, they tend to a higher risk of proceeding to amputations. Next slide. And also that it is a higher mortality rate because if you have ischemic damage to the foot, there's also some chance that the similar processes are occurring in the brain and the heart. So at least at the data when that was collected for that period of time, you have reduced survival in people who have some element of ischemic component to their foot ulcers. Next slide. Now, sadly, when a person with foot ulcer comes to for medical care and they're treated in a modern tertiary center with the aid of a diabetes doctor, a podiatrist, a surgeon, a vascular surgeon, perhaps the orthopedic surgeon, the orthotists, the nutritionist, even after this is done to the best of the multidisciplinary team's ability and a foot is deemed healed, unfortunately, there's a very high risk of recurrence on the same or the other foot at 1 year, about 40%, and can be as high as 65% at 3 to 5 years. And so essentially, if you want to save limbs, it is preventing the first ulcer, because sadly, by the time you've had the ulcers and the first sort of set of treatment, there's a high risk of recurrence. Next slide. And this again, data comes from a group which is active in this area in the US. And what they've been trying to do, they've had 2 publications over the course of 5 to 7 years, and this is the latest one, is that what people don't realize is that if the 5-year mortality of a person with diabetic foot complications, whether it's an ulcer, whether it's a deformity, it's as high as all cancer mortality, which you can see in the purple bar column there. And some of them, like minor amputations or CLTI, stands for chronic limb threatening ischemia, or a major amputation, it can be even higher. So you have in cancer mortality, you would think that breast cancer has the best mortality, best survival rate or lowest mortality, lung cancer, pancreatic cancer worst, and this foot disease, compares with the all cancer mortality, but if it's an amputation or serious blood flow restriction to the foot, the 5-year mortality can be quite similar, above or comparable to lung and pancreatic cancers. And this is something that people don't realize. It's not a problem that needs to be taken lightly. Next slide, please. So quickly on the management principles, next slide. I've alluded to this before, but basically you need a multidisciplinary team, and that involves a podiatrist who look after the wound, a vascular surgeon if there is blood flow damage to revascularize. You need the orthotist, orthopedic, the infectious doctors. All of us should be educating a person with foot problems and also measuring their making sure the blood sugar levels are optimized. Next slide. And I've got a couple of slides here just to show that this is the pathway. So idea is anybody in the community, they see it, they should refer people with ulcers early, not wait. And so this is a pathway. This is the Central Adelaide Local Health Network pathway, but a similar one will be developed by most health services across the country. These are given out in the community so that the GPs and podiatrists and other healthcare providers can refer people early rather than late. Next slide. And that's part 2 of the same sort of flyer that is sent out to healthcare practitioners. Next slide. And finally, I mean, there's increased recognition for this problem. As it is, it's a big burden, foot disease, particularly so in these communities. And currently, there is a federally funded grant for about 3 years, which the principal investigator is Professor Alex Brown, who's an Aboriginal researcher based at the SAMRI in South Australia. And so it's to come up with a nationwide comprehensive policy. I'm fortunate to be a part of this collaborative effort, and the idea is that we respond to the challenges and we come up with a mechanism to identify people with foot disease and treat them, knowing that the disease is very common, tends to happen at an early age of onset, and is quite aggressive. With that, I will conclude. I apologize again for the technical glitches, and I'm happy to take any questions if there are any.
Thank you so much, Chinmay. I'll just stop sharing. Does anyone have any questions? If you could put them in the web chat, that would be terrific. Perhaps I'll start with a question. I was just wondering, what are the factors responsible, like the primary factors responsible for the increased prevalence of diabetes in these communities, and specifically in females? I mean, you mentioned gestational diabetes, but does that account for the vast majority, like that increase in females versus males?
Well, the answer, as most things, is we're not entirely sure, because of the lack of the studies, but there has been, as you know, diabetes prevalence has shot up in the last few years. So one, clearly westernization of diet has made an impact. So you will know the easy access. So for example, the Aboriginal healthcare center I see in remote South Australia, right next to it there's a new Krispy Kreme outlet. So that does not help. So with the staff and others. So these are things that there's clearly a diet component, but also there are studies and that different ethnic populations have a variable propensity to develop diabetes. So basically, diabetes is the diabetes basically means chronic high blood sugars, and so the thing is, not all obese people are diabetic, but if you are obese, you're putting more strain on your body to make a lot of insulin, and you're not able to control your blood sugars. And certain ethnic groups are probably more likely. So, for example, the Mexican Americans are high. The American Indians are high group. The people in Australia similarly are in that group. So there is part ethnic, part dietary and lifestyle issues. And also what I know from the centers is that, from what the community says, that their lifestyle has changed. They're getting less exercise and they're getting more of these easily available easy carbs. But there's been no good study to say that if we reverse the pattern, it's intuitively possible that the communities, when they were having leaner meats, more locally sourced food, when the exercise levels were higher, but there's been no real data which show that this intervention reverses the trend. But that is the most likely cause. Regarding the gender disparity, again, it's not clear if it's more in women, because a lot of these studies rely a lot on self-reporting and also in who participates. And the studies in which women tend to participate more, particularly around pregnancy period. So we commonly get a lot of involvement during pregnancy and very little after delivery. So that also, again, so incentives matter. So I don't know if there's a clear-cut answer to an increased prevalence in women. This is just what the studies show. I have tried to get these studies. I mean, not a whole lot is done, and they're done sporadically. So it's from the data we had locally.
Thank you, Chime. Prue has asked a question. Can you comment on nuclear medicine imaging for diabetic foot and ischemic heart, which certainly a few years ago was performed particularly in the US?
Yep. So with the foot disease, clearly there's a role for, I mean, the major problem with foot disease is infection, and infection down to the bone, and there is osteomyelitis, and that seems to really accelerate the progression to amputation. And often the nuclear medicine modalities in that context are generally, I mean, you would still do an MRI scan, but often we have to use PET scans to delineate that. So there's clear role in that regard. The second part of the question I didn't understand with regard to cardiovascular. Is it in the notes here? But clearly there's a role in the peripheral imaging. With regards to the ischemic heart disease, yes, you have the role for nuclear medicine. However, there are also interventional studies. So these ones are reserved for people where you cannot do, dynamic stress testing. But there is clearly an increasing role for PET imaging in both ischemic heart disease as well.
Terrific. Prue Burns has asked a question about compliance in regards to treatment, for example, drugs. So are there any issues with, compliance as far as taking medications? Like some of these GLP-1 agonists are given via subcutaneous injection. Are there issues with compliance there? Yeah.
So currently we are running a study which is looking at the 10-year, I haven't been there for 10 years, but one of my colleagues has been visiting for 10 years. And we are trying to see how the medication usage has changed and how much compliance there is with regards to these medications. So as I said to you, there are about 8 types of treatments. 6 of them are tablets and 2 are injections. Just anecdotally, so once we get those results, I might be in a better position. But there are some injection modalities, and they're very attractive. They're available as once a week, and they're available, and they cause weight loss as well. Now, some of these patients who are engaging with these Aboriginal health rural centers, they could just visit the healthcare center once a week, and the nurse gives them that injection. So actually, in some ways, those who are engaging, they find it an easier option than taking tablets daily. But anecdotally, it is not great. But I'm seeing that with the once a week injection, once they have weight loss, but again, it's to do with people who want to engage. So we find that, women trying for pregnancy are more engaging. The Aboriginal healthcare staff at the rural tend to be more engaging, and there's some who just we fail to get good compliance. But it goes both ways. Some prefer tablets, but the once a week option, because of is the option they could just turn up once a week and have it done. That with a short minority seems to be working, but it's all anecdotal. We are currently looking at the 10-year difference in both prescription patterns as well as the compliance, and we're doing that study at the moment.
Because one of the benefits of them coming in once a week to meet with a nurse is the nurse has the opportunity to check on the blood glucose levels and also to have a look at their feet.
Absolutely.
Risk of amputation.
It is all opportunity based.
Also is missed.
Yeah, absolutely. And the nurse is trained for eye scans. So you take any opportunity to just do the screening. So the centers I visit are very well supported. That's they have eye scans. They have a 3-monthly blood test, HbA1c monitor that is a point of care, and a urine test. So they would try and do much. We are trying to improve both education just for the health workers regarding the foot. The foot tends to be neglected, but we are hoping that with the current grant that I mentioned, the federal one, that the one major part of that is to increase awareness. But with other aspects that we take the nurse or the healthcare worker takes that opportunity to get as much done when a person turns up. Yes.